This is Janice Lopez from the International Organization for Migration, and welcome to the Migration Health Research Podcast. In this issue of the Migration Health Research Bulletin number 22, we feature studies, reports, and book chapters on topics relevant to migration and health such as disability, infectious and non-communicable diseases, mental health, border management, and human trafficking. For this audio podcast episode, we have included two interviews. One with Violina Nazaria, project coordinator based in IOM Chisinau, who will discuss the challenges in accessing healthcare and social services faced by trafficked persons in Moldova. This will be followed by an interview with Haley West, Migration Health Senior Program Officer in Health and Emergencies based in IOM Headquarters, who will talk about the importance and utility of IOM's health border and mobility management framework. Let's listen to Violina Nazaria.
The Republic of Moldova remains primarily a source country for women, children and men subjected to trafficking of human beings. Today, few studies exist regarding the health consequences of human trafficking, and none has been conducted on the health needs of victims of trafficking for labor in Moldova. The primary goal of the study, Health Impacts on Victims of Human Trafficking, was to outline trafficking exposure and its health consequences for survivors. This study was intended to help fill gaps in the literature, with results aimed at developing recommendations to foster the development of integrated health policies for more informed responses, strategies for specialized health service provision, and individualized care for trafficked persons. The current study is actually based on the analysis of quantitative data collected from 99 individuals and qualitative data from 24 additional persons. All were victims of external or domestic trafficking, and all participants in the study were receiving post-trafficking assistance services at the Center of Assistance and Protection that at the moment is within Ministry of Health. Participants were interviewed within the first 2 weeks of their contact with their selected service, and as a research tool was used the standardized questionnaire Trafficking, Exploitation and Abuse, developed by the IOM and the School of Hygiene and Tropical Medicine from London. This questionnaire was previously used in another similar study developed in Mekong region. The questionnaire consists of 6 parts, including 67 questions, such as background and demographic information, physical health symptoms, exploitation exposures, sexual and reproductive risk, recruitment stage pre-trafficking experiences, and emotional well-being. 3 focus groups with 8 participants in each were also organized within the Center of Assistance and Protection in Chisinau. The goal of the focus groups was actually to provide in-depth exploration of victims' access to health care and social services in a post-trafficking situation. The 24 focus group participants were individuals who had previously been supported by the Assistance and Protection Program within the Center of Assistance and Protection.
Can you tell us a bit more about the findings from the study, especially in terms of the health condition and access to services of trafficked persons in Moldova?
The key findings identified in the study indicate that most victims worked continuously 7 days a week, and 2/3 of the victims had been enslaved for up to 6 months. The majority of victims reported that they had been working while ill or experiencing starvation, mistreated by restrictions of food and water. Each second person resided and worked in insanitary and harsh climatic conditions. Pain and physical exhaustion were the main symptoms reported by the victims. Also, physical health problems consisted mainly of headaches as well as pain in the lumbar spine and pelvic regions. Each third woman complained of gynecological pain, given the fact that they were forced to provide sexual services. And each fourth person presented memory disturbances and experiences of events associated with trauma and physical injury. Mental health impairments in the early period after trafficking were identified in half of the cases as permanent nervousness, insomnia, and unreasonable fears. Many victims reported lack of interest in life, lack of energy, and emotional distress. Most of the victims felt ashamed of having worked as a prostitutes, of having made their family ashamed, and half of the cases expressed feeling betrayed by their family, the government, society, and those responsible for their having been trafficked. In this study, I would like to emphasize that 62% of participants indicated they needed medical care while being in trafficking situations. However, only 4% unfortunately reported having contact with professional medical practitioners, for example, doctors and nurses, during that time. Focus groups qualitative study helped us to identify challenges associated with accessing health and social services in a post-trafficking situation. Only a very small percentage indicated that they would share their emotions and experiences of trafficking with other people. Most commonly, lack of confidentiality and fear of stigma were the primary challenges for victims seeking medical care or assistance from service providers. The focus group discussions highlighted the complexity of the reintegration and assistance process. Our findings showed that the stigmatization and victim blaming prevents well-being and their healing process. Partially, this attitude is supported by the insufficient capacity of the public health system and the deficiencies of the national legal framework and national referral mechanism that should help the victims to receive necessary services and to feel protected.
As my last question, Violina, can you tell us a bit about how do you think would this study contribute in improving access to healthcare services among trafficked persons in Moldova?
I think that further development of the legal framework that would ensure the free provision of health and social services and legal protection of the victims is very necessary. Mainly, this refers to the development of the legal status of the national referral mechanism and provision of the temporary free coverage by the national health insurance of the recognized victims for addressing their health needs. As well, an appropriate legal framework should be coupled with a closer cooperation between the relevant state authorities of all levels, especially those responsible for victim identification and timely provision of services. Referral mechanism should recognize the need for informed consent, confidentiality, and privacy of all individuals. Additionally, the collaborative efforts between the state and civil society are very essential element that could create a supportive basis for the successful reintegration of victims in the country. Results of this study could also help to inform decision makers, those in leadership positions, who are able to create informed and responsive policy to effectively identify, intervene, and provide services to victims of trafficking within the Republic of Moldova.
Now, let's listen to Haley West.
The framework, really, it has two aims. First, it looks to ensure that governments and communities have the capacity to address the mobility dimensions of public health threats. And secondly, it looks at affected and at-risk populations and how do they benefit from appropriate and timely support using particularly inclusive and rights-based approaches that leave no one behind. And we've seen this to be very, very important in the context of COVID-19, where governments were looking at planning and implementation of COVID-19 strategies, whether that was during the initial stage of the outbreak in terms of access to testing and treatment, but also also now in 2021, as we've been working on COVID-19 vaccination access for these populations that are oftentimes not considered in these plans. And so the IOM Health Border and Mobility Management Framework really tries to look at all, how these populations interact, how mobile and migrant populations interact with host communities, and why it's really important to not only apply a mobility lens to our public health programming and planning processes, but also to ensure an inclusive and leave no one behind policy as well. The framework is organized around 5 strategic objectives that are operationalized through a set of interrelated, sort of mutually supportive core activities. So the first one is enhancing evidence and evidence base on the human mobility dimensions of communicable disease. And we do this a lot through what's called population mobility mapping, which is a 3-step process that involves trying to understand what are the mobility trends within a certain particular area. This can be at a national level, or it can be done at a district level, or even at a community level, to look at what are the mobility trends, how are people moving, why are people moving, where are they going, what direction, what are the volumes and the flows, and to be able to then use that information to identify targeted areas where public health interventions such as health screening or such as vaccination, such as risk communication and community engagement can be done in a more targeted manner to make sure that we're not only just reaching static populations, but also these mobile populations and migrant populations. The second objective of the HBMM framework is really strengthening health systems, particularly border health capacity. But again, we're looking at the entire health system. So if we see trends of movement across a community, or even at a much higher level across at a national level, we're looking at that entire continuum of that mobility and trying to look at how do we strengthen the health system, not only in border communities, but also as we know that there's a lot of secondary migration, internal migration within countries. Then the third objective is really to enhance that community engagement and empowering migrants, mobile populations, and host communities. And again, this is really an important point to ensure the equity aspect of the work that we're doing and how we're supporting member states. And then the fourth objective is really promoting mobility sensitive and inclusive policy, legal, and strategic framework. So this is important to understand about the framework, is that it's not only just looking at the operational components of what IOM can be doing to support member states and support communities, but it's also looking at a much higher level. How are we using that enhanced data that I mentioned earlier in Objective 1 to then target our interventions and activities in communities and build the health system to then also feed into the policy level discussions around how do we make our health policy and our health systems more mobility sensitive and inclusive. And then the last objective of the framework is looking at strengthening multi-sectoral partnerships and coordination, including cross-border and internal coordination. And this is really important. It particularly is also a part of the fact that the framework doesn't only have to be used for response. The framework provides a structure or an outline for how IOM can also support member states on the preparedness side and after the response on the resilient recovery from health crises. So really looking at a multi-sectoral response, and this relates to how IOM is. We aren't a health agency, and so what IOM can bring to the table in discussing this with ministries of health and other ministries that within your mission might be important is bringing different thematic areas to the table. So when this HBMM framework was revised and developed again, it was actually done in collaboration with our immigration and border management colleagues, as well as our water and sanitation and hygiene colleagues. Again, looking at different aspects, different areas that impact health and different areas that we might need to work together.
Can you elaborate more on how the framework has been useful in supporting IOM member states and partners, as you have mentioned earlier? For example, if you have any particular scenario or example in mind on how this has been beneficial in crafting a policy or program at the national or regional level.
The framework really looks at how IOM can undertake activities related to, of course, The title, Health, Border, and Mobility Management, and particularly serves as a reference for IOM member states and partners to understand IOM's role and contributions in this area of work. So we really do encourage missions to use this when they are in discussions with member states, looking at what are the different types of programming areas, what are the gaps, what are the needs, after they've done their assessment, and using the HBMM framework as a guide, looking at the different programming areas of health, both from a preparedness, a response, and recovery types of angles. And again, this also is very much linked to the global health security agenda and the international health regulations, which missions can also refer to when they are discussing this framework with member states. Under the framework, there are a lot of activities. So the activities range from collecting an analysis of information on mobility dynamics through population mobility mapping. As I mentioned before, we've done this in a number of countries. One of the good examples that I have is from the Ebola outbreak in DRC, where IOM conducted 12 of these exercises in response to the outbreak. And in particular, this was used, again, this mobility information was used in the planning and the response, the actual operations, to be able to target certain activities, whether, again, that was Ebola vaccinations or Ebola risk communication and community engagement type of messaging, or set up health screening points at particular areas where we knew that there was a lot of mobility flows. There were high levels of mobility, whereby it was actually quite interesting to see that there were suspected Ebola cases that were identified and even some confirmed. The other thing that is interesting is when it is used for policy. So in South Sudan, the framework, and particularly the population mobility mapping aspect of the framework, was used to inform EVD policy back in 2019. And this was an exercise where the Ministry of Health really gathered all the key stakeholders, and IOM was able to bring in this mobility lens, not only at the points of entry, but more broadly looking at secondary migration within the country and how we could support the government to develop a policy on preparedness for Ebola. And last, other activities within the framework, and again, it's quite far-reaching. It also includes infection prevention and control, mental health and psychosocial support, and that multi-sectoral cross-border coordination, disease surveillance, and also vaccination. So the last example I wanted to bring to you is from our mission in Guinea that has used the HBMM framework to really look at how to identify zero-dose children along the mobility continuum who have never had access to preventative vaccination, whether that's polio or measles or diphtheria previously. And so they actually used the framework to develop an approach that looked at trying to understand, using the mobility data to understand, are there communities that we're not reaching? How do we reach them better, whether that's through more migrant-friendly services at health facilities? What does that look like? Maybe it's information, education, and communication tools are translated into appropriate languages and are culturally appropriate for those communities, but also trying to identify how these communities move and where are the particular locations where it makes sense to invest in a public health intervention, again, whether that be RCCE or some type of health screening, and in this case, vaccination. So it was really taking the vaccination to the communities at the lowest level and trying to reach these communities. And what we're seeing now is that we're trying to also use this now in our new partnerships with Gavi at both country level as well as global level. We're seeing that there's really a value add in understanding mobility in order to target public health interventions that aren't necessarily always different from the hosting and the mobile or migrant communities, but it's the way in which we target those communities that might be different. And we're starting to see interest from other partners, whether that's Global Fund or Gavi or the Health Cluster, in looking at how we are doing this and how this can be integrated into broader public health planning and implementation and policy across the spectrum, I think, of public health issues.
Thank you very much, Violina and Haley. And thank you all for listening. Please feel free to share your feedback with us. See you on the next podcast.